بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the next lecture in the series of brain imaging, and here we are dealing with the imaging of intracranial vascular lesions. Actually, we will handle these specific topics, including the imaging of the aneurysms, arteriovenous malformations, cryptic arteriovenous malformation, the imaging of cavernous hemangiomas or the cavernomas, the diagnosis of developmental venous anomalies, and the diagnosis of the aneurysm of the vein of Galen, and finally we will discuss the moya-moya disease. Starting by the intracranial aneurysms, and this is the overall frequency, which ranges between 1 to 10%, and the annual risk of rupture is about 2% of the intracranial aneurysms. We have three main types of intracranial aneurysms, which are the secular type, the most common, the fusiform, and the dissecting type. Aneurysms may be solitary, and this is common in about 75% of cases, and may be multiple in about 25% of the cases. And the aneurysms may usually develop spontaneously, and in many cases they are asymptomatic until rupture occurs. In secular aneurysms, or what is known as berry-like aneurysms, they appear on imaging as outpouching from the arterial wall, usually at the regions of the arterial bifurcation. Berry aneurysms or secular aneurysms are very common, or the most common type of intracranial aneurysms, representing about 65 to 98% of the intracranial aneurysms. And most of these aneurysms are located in the anterior circulation, and 15% of these aneurysms are located in the posterior circulation. The most common sites for intracranial aneurysms in the anterior circulation are in the region of the anterior communicating artery and the region of the posterior communicating artery, as well as in the region of the middle cerebral artery. These are the common sites of intracranial aneurysms in the anterior circulation. And actually, you know that the most common site is at the anterior communicating artery, either to the left or to the right of the midline. Then intracranial aneurysms, 15% occur in the posterior circulation, and 50% of these 15% represent the basilar tip aneurysm, or the aneurysm of the basilar tip. Then the rest of the 50% of the posterior circulation aneurysms are belonging to other vessels in the posterior fossa. Then and if you look here, and you can see this is a good example of an aneurysm of the tip of the basilar artery by the axial contrast CT enhanced scan, and you can see a small and a secular aneurysm at the tip of the basilar artery, which is nicely demonstrated by the digital subtraction angiography. And you can see the aneurysmal sac at the tip of the basilar artery. This is the posterior cerebral artery on both sides. And this is the 3D reformatted image, also show the aneurysm at the tip of the basilar artery. And the clinical presentation of aneurysms are usually due to the complication, which is the rupture. Then most of the aneurysms, as written here, remain undetected until the time of rupture, and the rupture will result actually in the subarachnoid hemorrhage, And the very common symptom of subarachnoid hemorrhage is that the worst headache in the life of the patient. And this headache is very severe, and it may be associated with brief loss of consciousness, nausea and vomiting, or focal neurological deficits. Then the second type of aneurysms is the fusiform aneurysm, and this aneurysm has no neck, and this is just the fusiform dilatation of the vessel, and is nicely demonstrated by angiography. Then you can see here by the DSA angiogram the fusiform aneurysm of the distal part of the common of the internal carotid artery, as you can see here. And these aneurysms, as I have said, they have no neck, and they have a long course with circumferential involvement of the vessel. Any type of the aneurysms, especially the large one, may be partially thrombosed, of course. And this is an example of a fusiform aneurysm along the distal part of the internal carotid artery. And you can see the dilatation of the vessel and the absence of a demonstrable neck for this type of aneurysms. And dissecting aneurysms are relatively uncommon, and actually dissection occurs in the extracranial carotid and the vertebral arteries more common than dissection in the intracranial vessels. And if dissection occurs in the neck vessels, it will result in ischemic strokes, especially in young adults, while dissection intracranially will result in subarachnoid hemorrhage instead of a stroke. And this is the incidence of dissecting aneurysm at the autopsy cases, which is about 4.5%. Then infectious aneurysms or mycotic aneurysms are commonly related to septic emboli, especially in cases of endocarditis. And you can see that this aneurysm is diagnosed by the clinical picture of the patient, and you should know that the patient has a source for septic emboli. Then you can assume that the aneurysm is of the mycotic type. And mycotic aneurysm here is occurring at the origin of the superior cerebral artery, cerebellar artery, and you see this very small aneurysmal sac in no patient with bacterial endocarditis, and the spasm of the vessel has resulted in an infarction in the territory of the affected vessel, as you can see here in the FLAIR and T2 weighted MR images, showing a signal abnormality in the right side of the bones, both in the T2 and the FLAIR imaging, representing the ischemic area. And this is the 3D reconstructed image, and you can see the aneurysm at the superior cerebellar artery. Then oncotic aneurysms are those related to malignancies, and sometimes I don't have actually an example intracranial my oncotic aneurysm, but this is a good example of a patient with a bronchogenic carcinoma that has affected the right pulmonary artery, weakened the wall of the artery, and the artery started to form a Forbes aneurysm here, which is known as oncotic aneurysm. And this is the chest X-ray, and you can see a mass in the right upper lobe. And by the coronal reformatted CT imaging, you can see the small aneurysmal bulge from the wall of the right pulmonary artery. And this is the selective angiogram. You can see the oncotic aneurysm. And these aneurysms are usually treated interventionally by coils to prevent rupture, because the risk of rupture is high, and hence the mortality rate is also high. Then aneurysms may be associated with arteriovenous malformations. Both can occur in the same area in the same patient in about 25%. And approximately 50% of these aneurysms are located on the feeding artery, while 25% are located within the nidus of the arteriovenous malformation, as we will discuss with this abnormality just later on. Then in this CT scan, and you can see this is an aneurysm in the region of the anterior communicating artery, and you can see the aneurysm by the selective angiogram, and also you can see the arteriovenous malformation. This arteriovenous malformation is mainly supplied by the anterior cerebral artery. It may have branches from the middle cerebral artery also, and you can see the area of vascular malformation, and can see also the calcium inside the lesion. And the appearance of aneurysm on the non-contrast CT scan, sometimes if the aneurysm is small, you cannot see it, and the scan will be interpreted as normal. But if the aneurysm is a little bit sizable, then you can see faint hyperdensity at the site of the aneurysm, like here, and you see a small aneurysm at the tip of the basal artery, which is relatively hyperdense in this non-contrast study. If the aneurysm is more sizable, then you can detect the calcium in the wall. If the aneurysm has ruptured, then you can see the subarachnoid hemorrhage as a complication of rupture of the aneurysm. And this is the CT angiogram demonstrating the basilar tip aneurysm, which is homogeneously enhanced, denoting that the aneurysm is not partially thrombosed. And this is reformatted images along the course of the internal carotid artery on the right side, showing a supraclinoid aneurysm, saccular aneurysm. And this is the coronal, and this is sagittal oblique reconstruction, nicely demonstrating the artery and also the aneurysmal sac, which does not contain any thrombus. Then giant aneurysm is, by definition, is the aneurysm which is more than 2.5 centimeter in diameter. The incidence is about 25% of all types of aneurysms. And these giant aneurysms are usually located supratentorially. Then whenever you see an aneurysm which is larger than 2 centimeter, 2.5 centimeter in diameter, then you consider it a giant aneurysm. Oh, and of course, these giant aneurysms are more liable to rupture than the smaller ones. And whenever the aneurysm is giant, it is liable for internal thrombosis. And here, this is a giant aneurysm in the suprasellar area. This is the patent lumen, which is homogeneously enhanced, and this is the thrombosed lumen, which shows the mural thrombus inside the aneurysm. Then this is the case of a leaking giant aneurysm in the middle cerebral artery territory. And here you can see in the pre-contrast scan some calcium in the wall of the aneurysm, and also hyperdensities representing recent blood in the area of the aneurysm, and outside the aneurysm you can see some hypodensity, which represents the brain edema. After contrast injection, and you can notice the enhancement of the patent lumen, and this is the thrombosed lumen, and the perianeurysmal leakage or hemorrhage, and also you see an area of perifocal brain edema. And this is the CT angiogram of the same case, showing the aneurysm and the perianeurysmal leakage, which is pointed to by arrows. Aneurysms by MRI, especially if they are patent, have a classic appearance, and this appearance is due to the turbulence of flow inside the aneurysm itself. Then you will see a well-defined lesion, which is usually signal void along the course of one of the vessels, showing characteristic whirly appearance, which is due to turbulence of flow inside the aneurysm. And this is classic appearance of the aneurysm, especially seen in the T2 weighted image. And you can see these artifacts which are due to the turbulence of flow inside the aneurysm, and this is a pointing point for the diagnosis of the lesion as an aneurysm. In the T1 weighted image, you may see this phenomena, but it's very clear in the T2 weighted image compared to the T1 weighted image. In the T1, you can also see the thrombosis inside the aneurysm, and you can also detect a hemorrhage in the perianeurysmal area. And this is the middle cerebral artery aneurysm by MRI T1 weighted image in the axial and in the coronal planes. And here you can see the aneurysm, and you can see some hyper intensity within the wall of the aneurysm, denoting thrombosis, and the different ages of the thrombus, ranging from acute blood to subacute blood, will show different signal intensities. And this is the case of bilateral internal carotid artery aneurysm in the region of the cavernous sinus, and the aneurysm is more sizable on the right side, showing the characteristic whorly appearance on both sides, diagnostic of an aneurysms. And this is also a giant aneurysm in the internal carotid artery on the left side. And this is the digital subtraction angiogram, and this is the MRI T2 weighted image showing the aneurysm and the turbulence of flow inside the aneurysm. Then we came to the arterial venous malformation, and the arterial venous malformation is relatively more common than the aneurysms, and about 80% of these vascular malformations occur before the end of the fourth decade, and 20% usually seen in young adults below the age of 20 years. 90% of arterial venous malformations occur supratentorially, and 10% occur infratentorially. The most common clinical presentations of vascular malformations are hemorrhage in about 60%, epilepsy or convulsions in about 34%, headache in 34%, and focal neurological deficits corresponding to the site of the vascular malformation in about 20%. In the appearance of the arteriovenous malformation in the non-contrast CT scan, the non-contrast scan may appear normal if the vascular malformation is small, but it may show hyperdense serpiginous structures representing the vessels contributing to the vascular malformation. Calcium in the wall of the vessels may be seen in about 20% of cases, and of course hemorrhage can be seen in the region of the vascular malformation. And this is an example of an arteriovenous malformation in the left parietal area, which can be hardly seen in the pre-contrast scan. After injection of contrast, and you can see multiple dilated tortuous vessels contributing to the vascular malformation, and note that there is no mass effect and there is no perifocal brain edema in this case. Sometimes a vascular malformation will present by an intracerebral hemorrhage, and this hemorrhage is usually seen in younger patients and in abnormal or the unusual location of the hypertensive hemorrhage. You know that hypertensive bleeding occurs usually in the temporoparietal area, and in patients who are hypertensive and diabetics maybe. But this bleeding, which is on top of arteriovenous malformation or other vascular malformation, will occur in unusual site and usually in a younger age. If you look here, and you can see only hemorrhage in the posterior parietal area, and this patient with sudden headache and vomiting. Then this is the angiogram, which has detected an underlying vascular malformation. And actually, this is a female, a child, 14 years old, presented by sudden headache and weakness of the right lower limb. The CT scan showed a hematoma in abnormal, in unusual location, and this is the high parietal area. And because of this young age of the patient, you may suspect an underlying pathology, and MRI is one of the helpful diagnostic tools to discover the underlying pathology, and also the the selective angiogram may help. And here you can see in this area, this is the hematoma, and you can see the small vascular malformation, which is consisted of multiple slightly dilated signal void vessels along the anterior aspect of this hemorrhage. Then the arteriovenous malformation, by contrast enhanced scan, will appear as serpentinously enhancing structures, and calcium, of course, may be seen in the vicinity of the vascular malformation. If this vascular malformation is small and uncomplicated, you cannot see any perifocal brain edema, and you cannot also appreciate any mass effect. But because of the shunting from the arterial side to the venous side without passing the blood through the capillaries, will result in ischemic changes in the vicinity of the arteriovenous malformation, which will present as areas of infarction or gliosis. Then hemorrhage in the arteriovenous malformation site may result in a mass effect and the compression of the ventricle, and also hemorrhage in the subarachnoid space may lead to the development of hydrocephalus. By MRI, you can see multiple dilated tortuous signal void vessels in the region of the vascular malformation in all pulse sequences, in T1, in the proton density and the flare, and in the T2 within image. And if you use the flow sensitive techniques, then you can see the flow within the vascular malformation. Usually, if it is sizable like this one, it may exert some mass effect on the adjacent ventricle and sulci. Then in this child, and the same patient, and I have shown it to you before, you can see the hemorrhage and the arteriovenous malformation, which has been confirmed by the selective angiogram and also the MR angiogram. And I have to say that the MR angiogram may fail to demonstrate the small vascular malformations, but of course the selective angiogram is both diagnostic and may be used for therapeutic embolization of this vascular malformation. Then what is the aim of imaging in cases of arteriovenous malformation? The aim is to detect the main arterial supply of the abnormality and the main venous drainage, and you detect if there are associated aneurysms along the feeder or along the nidus, and if there is ischemic changes due to shunting of the blood, or there is bleeding in the vicinity of the vascular malformation. Actually, when you have the full series of the exam, you can easily detect the main arterial supply and the main venous drainage, and you can also see if there are some aneurysms in the vicinity of the lesion, and the detection of ischemic changes is easy, as well as the detection of bleeding as well. And this is an occipital vascular malformation, and this is the reconstructed MR angiogram. And you can see that the vascular malformation is supplied by the posterior cerebral artery, which is a little bit dilated, and the branches are also dilated and tortuous, contributing to the main blood supply of this lesion. And also you note that the posterior communicating artery is dilated compared to the left side, denoting its share in this blood supply. And if you have the rest of the images, and you can see the drainage to the transverse sinus, for example, and you can provide all the needed information. You remember that aneurysms and arteriovenous malformation can occur in the same patient in the same area, and the incidence is about 25% of the cases. And I have shown this patient before. You can see the aneurysm in the region of the anterior communicating artery by DSA and the CT enhanced, contrast enhanced CT scan, and you can also the arteriovenous malformation, which is located higher up in the parietal area. And you can also appreciate the presence of calcium inside the lesion. Then this is a vascular malformation between the internal carotid artery and the cavernous sinus, what we call the carotid cavernous fistula. And this fistula will result in abnormal communication between the artery and the cavernous sinus, resulting in increased pressure in the inside the cavernous sinus, with engorgement of the veins draining into the sinus, especially the superior ophthalmic vein, which will be markedly dilated, and the patient will have proptosis. Most of the carotid cavernous fistulae are secondary to trauma, but sometimes there is no history of trauma, and the cause may be due to arteriosclerosis or congenital defect in the media of the internal carotid artery, or there is a carotid artery aneurysm that has been ruptured inside the cavernous sinus. Then what are the diagnostic landmarks for carotid cavernous fistula? First of all, you see that the cavernous sinus is enlarged and is homogeneously enhanced. Then if you look inside the orbit, you can see that there is some proptosis of the globe. And if you look at the region of the superior ophthalmic vein, and you see marked dilatation and tortuosity of the superior ophthalmic vein, which is one of the diagnostic criteria of carotid cavernous fistula, we compare this dilated tortuous superior ophthalmic vein by the normal appearance of the superior ophthalmic vein on the left side. And this is the way how to occlude the carotid cavernous fistula by the interventional techniques, and by fixing a balloon or so at the site of the defect in the wall of the artery to prevent the communication between the artery and the sinus. And this is a selective angiogram showing the region of the carotid cavernous fistula and the markedly dilated superior ophthalmic vein. Then a small partially thrombosed arteriovenous malformation is known as the cryptic AVM. And the cryptic AVM, by definition, is a small vascular malformation that has bled once and then became thrombosed. Then you will see two or one vessel which is thrombosed, and in the MR images, thrombosed vessel will show bright signal in all pulse sequences because of the presence of subacute blood. And this is an example. And you see in the frontal lobe on the right side, high signal in the T1, high signal in the proton density, and high signal in the T2 weighted image. And this is surrounded by a low signal rim of hemosiderin, maybe some edema, maybe not. But usually there is no mass effect and there is no flow detected in the angiogram. And this is an example of a very small cryptic arteriovenous malformation in the frontoparietal area on the left side by CT scan, and you see the surrounding area of edema or maybe gliosis. Then we came to the cavernoma or the cavernous angioma or the cavernous hemangioma. The cavernous hemangioma represents about 15% of all the vascular malformations, and the 80% of the hemangiomas occur in the supratentorial area, and 20% occur in the posterior fossa. Multiple lesions occur usually in 20 to 30% of cases, but in familial patients, and this lesion is familial, multiple lesions may be seen in up to 90% of the cases, as I will show to you. And cavernomas or cavernous hemangiomas is an abnormal lesion at the capillary level. Then 10% of the lesions will remain stable over time, 35% will increase, and 55% may decrease on the follow-up scans. And you should know that the usual size of this cavernoma is between 1.5 centimeter up to 2 centimeter. However, some of the cavernomas may be larger than this. Okay, then the cavernoma will appear on the CT scan as a focal hyperdense lesion in the pre-contrast scan. And this is the pre-contrast and this is the post-contrast. And you see focal hyperdense lesion, and it will show hyperdensities inside, usually due to calcium. And if you inject the contrast, it will show minimal enhancement. And it is not usually surrounded by edema. And if it is in the usual range of size, it does not exert any mass effect. On MRI, this cavernoma shows typical appearance. It is an area of mixed signal intensity, high signal and spots of low signal. The spots of low signal may represent calcium, and the high signal may represent the clotted blood. And a very characteristic hypo-intense rim of hemosiderin is usually surrounding this lesion. And like the CT, mild enhancement occur after contrast injection. And very importantly, if you do an angiogram, you will not show the lesion because there is no actual flow inside this lesion. Then this is the typical appearance of cavernoma. There is a small lesion which is usually of high signal in the T1 and the T2 with spots of low signal, maybe due to calcium or hemosiderin, but very importantly, the surrounding rim of low signal hemosiderin, which is seen in all blood sequences. Most of these lesions are not surrounded by edema, and if it is sizable, it may cause some mass effect. And this is the cavernoma by CT scan, and you see this is the pre-contrast study and this is the post-contrast study, and you can see the difference is little, and there is no edema, there is no mass effect. And cavernomas may occur in multiplicity, 90% of cases in familial patients and 25% of cases in the sporadic cases. And MRI is more better than CT in detection of small cavernomas. And here you can see this is a sizable cavernoma in the left frontal lobe, and this is the smaller one in the right temporal lobe, and you can see two very minute lesions nearby. These are multiple cavernomas. Then what are the clinical symptoms of these cavernomas? The most common symptom by far is seizures, and this is seen in about 55% of the patients. Other symptoms include focal neurological deficit in 30% of the cases. The cavernoma may bleed in 15% of the cases, and chronic headache is seen in about 30% of the cases. This is the cavernoma showing the classic appearance in the T1, high signal surrounded by low signal rim, and also in the T2 with the image with minimal amount of perifocal brain edema. Then you know that cavernoma may occur in the posterior fossa and in the cerebellum or in the brainstem, and it's stated in the literature that brainstem cavernomas never cause seizures. It may cause other symptoms like diplopia, ataxia, or sensory disturbances, but brainstem cavernomas usually do not cause seizures like other cavernomas occur anywhere in the brain. Then what are the exceptions of cavernomas? And the cavernomas may be multiple, it's well known. Cavernomas may be large than 2 centimeters in diameter. Cavernomas may be surrounded by edema, and you can see in this case by CT and MRI, and this is the cavernoma showing the classic hemosiderin rim outside. And the cavernoma may bleed in the cerebral parenchyma or in the subarachnoid space. And actually, you will think if the bleeding is sizable, it will mask the cavernoma. Then how can you know that this bleeding is secondary to an underlying lesion? Is the same like the arteriovenous malformation. The bleeding is in a younger age, and the bleeding is in unusual location. And this is a cavernoma in the right temporal lobe, and you see this area of bleeding nearby. The bleeding shows high signal in the T1 and high signal in the T2, denoting the subacute blood elements. And this is the cavernoma surrounded by the classic low signal rim of hemosiderin. Then the gradient image is very important, gradient MRI, for detection of minute cavernomas because of its sensitivity to hemorrhage. Then you can see this is the CT scan, and this is MRI T2, and this is the gradient image. In the CT scan you can only see this abnormality. In the MRI you can see this abnormality and this one and this one. But in the gradient image, because of the blooming effect, and you can see too many cavernomas. This is the classic appearance for the cavernomas. Then, as I have said, if you perform an angiogram for a patient who has a cavernoma, you will see a normal finding, because there is no flow in this at the level of the cavernoma. And this is a cavernoma in the thalamus, showing the classic configuration with the surrounding hypointense rim of hemosiderin. Then we came to the dural venous anomaly, or let us say the developmental venous anomaly, which is known as DVA, and the incidence of this lesion is about 2%. Actually, this is not a lesion, and it is considered by all as an normal variant. And you see this is a tuft of small vessels drained by a enlarged medullary vein. And on the CT or MRI, you can see the draining vein and the tuft of the small vein. And this is considered, as I have said, is a normal variant. Is a clinically silent lesion. It does not produce any symptoms. And you see here, this is a good example, T2 weighted image and T1 post contrast, showing the vein and the tuft of the veins drained by this medullary vein. It's very important to note that the developmental venous anomaly is a functional venous channel draining normal brain parenchyma. Then if you try to remove this lesion or to embolize this lesion, you will get an infarction in the brain. Then this lesion is usually known as leave me alone, and it is not an arteriovenous malformation, and it requires no intervention and no therapy. As you see here, this is a small vein with a tuft of veins exerting no mass effect, doing nothing. There are no surrounding perifocal brain edema, and you should not misinterpret this as an arteriovenous malformation. Then the detection of the developmental venous anomaly, especially if it is small, is usually difficult by CT, but it's easy by MRI, especially if you have the contrast enhanced MR scans. And sometimes the cavernoma may be associated with dural venous anomaly. And because of the intimate relation of the DVA to the region of the cavernoma, it is usually difficult to remove the cavernoma totally. And you know that the treatment of cavernoma is to be removed, because this is a source of epileptic fits. But the developmental venous anomaly should not be touched, because the intimate relation of the DVA to the cavernoma, sometimes the surgeons are not able to remove totally the cavernoma in order to save the developmental venous anomaly. Then we came to the vein of Galen malformation, and this represents about 1% of all cerebral vascular malformations and 30% of all pediatric vascular malformations. The vein of Galen malformation is actually a misnomer, and this abnormality is relatively rare. It occurs before the actual development of the vein of Galen. It appears in the 6th to 11th week of the gestation, after the development of the circle of Willis and before the development of the true vein of Galen. Then this is not a malformation and is not an aneurysm, but it is a fistula. This is an arteriovenous fistula between the primitive choroidal vessels and a vein which is the precursor of the vein of Galen, which is known as the median prosencephalic vein. This median prosencephalic vein will normally regress and the vein of Galen will develop later on. But whenever this fistula develops, it will result in abnormal communication between the choroidal vessels and this abnormal vein, which is known as the median prosencephalic vein. And because this is a high flow fistula, it commonly presents by congestive heart failure in the neonatal period. Whenever you see a CT scan or MRI, and you can see an enormously dilated signal void vascular channel in the region of the assumed vein of Galen, and is usually drained through the straight sinus into the confluence of the sinuses and maybe in the transverse sinuses as well. And this is, as I have said, a high flow fistula which commonly results in congestive heart failure. This is a CT angiogram of a patient with vein of Galen malformation, and you see the markedly or aneurysmally dilated structure in the region of the vein of Galen, which is drained through the straight sinus. Then the reconstructed image, and you can show nicely the region of the malformation and the drainage sites. This is also a case of vein of Galen malformation, and you can see this large aneurysmally dilated signal void structure in the region of the quadrigeminal cistern corresponding to the site of the vein of Galen in the T1 and in the T2 weighted image, and this is the angiogram showing the abnormality. And also here in this 11 months old male child or male presenting with seizures, and you can see the abnormal aneurysmally dilated structure and also the dilated straight sinus draining this abnormality. Another appearance of a vein of Galen malformation, aneurysmally dilated structure in the quadrigeminal cistern showing the signal void in all bulk sequences in the T1 and in the T2 weighted image. Actually, this is an easy diagnosis, but you should know that the aneurysm of the vein of Galen is a misnomer. Actually, this is not an aneurysm and is not a malformation. It is a fistula between the primitive choroidal vessels and the median prosencephalic vein, which precedes the appearance of the vein of Galen. Finally, we came to the Moyamoya disease, and Moyamoya disease, by definition, is an idiopathic, slowly progressive disease affecting the supraclinoid portion of the internal carotid arteries. This disease is of unknown etiology, resulting in marked narrowing or even complete obstruction of the supraclinoid part of the internal carotid artery. And you know, this is the normal carotid MR angiogram. This is the internal carotid artery, and this is the region of the carotid siphon. And after passing through the cavernous sinus, then it will start to divide into the anterior cerebral and the middle cerebral artery. Then occlusion of this part of the artery will result in this appearance, and you cannot see the middle cerebral or the anterior cerebral arteries, and also you cannot see their branches. Instead, you will see an area of collaterals or dilated vessels, which will appear on imaging like a puff of smoke. And this is the case of primary moyamoya disease in a female child 3 years old with left-sided weakness. And here, this is the internal carotid artery, but you cannot see the middle cerebral and cannot see the anterior cerebral. And instead, you see this dilated collateral vessels, and representing the enlarged lenticular striate and the thalamo-perforating arteries, as well as some of the dural and leptomeningeal vessels. And this will result in this appearance, which is known as the puff of smoke. Then if you look to the MR angiogram, and normally you can see the region of the internal carotid artery, and this is the middle cerebral, and this is the anterior cerebral. But here you can see the region of the internal carotid artery, but you cannot see the middle cerebral and cannot see the anterior cerebral, and you see this extensive area of collateral circulation. Also, this is a typical appearance of the moyamoya disease by conventional MRI. Then you see here in the T2 weighted image, normally you will see the internal carotid, the middle cerebral, and the anterior cerebral. In cases of moyamoya disease, you cannot see the major vessels, and instead you see these very small dilated perforators or collaterals, but the major vessels are not usually seen. And by MR angiogram, you see only the internal carotid artery, you cannot see the middle cerebral branches or the anterior cerebral branches. And also, the disease may affect the posterior cerebral arteries as well. Then in the children, moyamoya disease will present by ischemic strokes like cortical infarctions and so on. While in adults, moyamoya disease will result in affection of the white matter in the form of infarctions and maybe hemorrhages as well. And this is an example of moyamoya disease by carotid angiogram, and you can see the puff of smoke. You cannot see the anterior cerebral, you cannot see the middle cerebral. The MRI images show multiple cortical infarction. Moyamoya disease may be primary or secondary, and then the secondary causes are usually the neurofibromatosis type 1, sickle cell disease, and radiation vasculopathy. All these diseases may result in progressive occlusion of the supraclinoid part of the internal carotid arteries and give the same picture of moyamoya disease as the primary one. And I thank you very much.